In this recorded lecture, I'm going to be talking about atherosclerosis, which is a cardiovascular disorder. It is necessary for you to have a very good understanding of the normal flow of blood throughout our body, through the pulmonary circulation and the systemic circulation, in order for you to have the ability to really grasp the concepts that are discussed throughout all of the cardiovascular disorders lectures and even some of the respiratory disorders lectures. So please make sure you have this foundation. So I'll now review the flow of blood throughout the body. Remember that the heart is made up of chambers. At the bottom we have the right and left ventricle, and at the top we have the right and left atria. I'm going to start with looking at blood returning to the heart, remembering that blood returns to the heart through veins. And this blood that returns to the heart is going to be deoxygenated. It's going to be nutrient poor and even contain waste products, such as carbon dioxide. As blood returns to the heart in the venous system, it's going to enter the right atria through the inferior vena cava and the superior vena cava, depending on where it's coming from. This blood will pour into the right atria, and from here it's going to move through a valve called the right atrioventricular valve into the right ventricle. This atrioventricular valve is also known as the tricuspid valve. And I wouldn't worry too much about writing down everything I'm saying right now because you can find this information everywhere. Just try to understand. Once blood moves through from the right atria into the right ventricle through this tricuspid or atrioventricular valve, it's then going to be pumped by the right ventricle into the pulmonary trunk. And this is a main pulmonary artery that comes off of the heart. And it moves into this area through a valve that is called the right semilunar valve, but also called the pulmonary valve. Blood moves into this pulmonary trunk and then will be pumped in two directions, the left and the right, making their way to the lungs. As this blood moves to the lungs and reaches the level of the alveoli, that's where gas exchange will occur, where carbon dioxide will be converted to a gas form that we can breathe off, and then what we'll do is we'll pick up oxygen that we breathed in. And now the blood that has picked up oxygen, now shown as a red color, needs to make its way back to the heart to pump it to the rest of the body. And so blood will move then to the left side of the heart, where it will get there via these pulmonary veins. So these pulmonary veins that you see on either side coming from each lung is going to bring blood into the left atria. The left atria will move blood into the left ventricle through another atrioventricular valve on the left side, also known as the bicuspid or mitral valve. From here, the blood that's in the left ventricle is going to now be pumped out of the heart and into the aorta. How it gets to the aorta is through a valve here that's called the left semilunar valve, but also known as the aortic valve. Blood will be pumped into the aorta, and it's from here that this strong pumping action is going to pump blood into the aorta, where it's going to move up through this aortic arch and then continue to move throughout the body, with its final destination being all of the different tissues in the body. So it's going to be moving through arteries, and then smaller arteries, you might recall, are called arterioles. And then it's going to, let's look in this example here, reach the capillary level, the arterial end of the capillaries, where this blood, this oxygenated, now nutrient-rich blood, is going to be deposited at the tissue so that those cells can use the substances found within the blood for their own metabolic processes and for survival. And then, of course, as those metabolic processes occur, they're going to use up the oxygen, use up the nutrients, give off waste products, which is going to now enter that venous end of the capillaries, where this blood is going to be brought into larger venous vessels that we call venules, into even larger ones that we call veins, and then it's going to be brought back to where we originally started through the inferior and the superior vena cava and into that right atrium, and so on and so forth. So the pulmonary circulation then is the circulation of blood throughout the pulmonary or the lung system, where we bring in that deoxygenated blood, we oxygenate it, and then it's returned to the heart. The systemic circulation is where that left ventricle is pumping blood into our system. Here is a simplified diagram on what I already discussed. Please make sure you understand what I've just spoken about before you proceed on. This will help you not just with today's lecture, but with many of our upcoming topics. Continuing on with reviewing relevant normal anatomy, quick reminder on the layers of blood vessels. So arteries and veins. Arteries and veins contain 3 layers that possess different components, and that will come up a little bit later as well in this course. But you can see that the most inner layer, which is an endothelial layer, this is the layer that blood is in contact with, is the tunica intima. Sometimes you'll see it as the tunica interna. Then just outside of that, so we're moving outward in our discussions, is the tunica media. You can think of that M as muscle, because this is the layer that is going to consist of smooth muscle, but it also consists of some elastic tissue. Then going more external, we have the tunica externa, and this is a connective tissue layer. So there is a bit of a difference between both because their functions are different. We need to have stronger muscle and arteries to pump blood into and throughout our systemic circulation and then into our tissues, whereas we don't need it to be as thick with veins. The tunica externa, that connective tissue layer, is, as you can see, thicker in veins than arteries. And the reason for that is to help prevent collapse of the blood vessels and help protect them from damage. A lot of veins are located more superficially, and so they're anchored in a different way. The other thing I wanted to point out here that's very important is the presence of valves within veins. And when we talk about veins in more detail, you'll see why this is relevant. But these valves just help encourage one-way movement of blood upward toward the heart, preventing it from pooling in areas such as the lower extremities. Another review of normal anatomy. Here is the heart, where you can see the blood vessels associated with it. And even though we know that the left ventricle pumps blood through the aorta to the rest of the body so that the tissues of the body can have the blood supply that they need, well, the heart is also a tissue. And the heart needs, in fact, quite a lot of energy in order for it to just keep us alive. And so how does the heart get its own blood supply? Well, it's kind of neat how it works. So remember that this left side of the heart here, the left ventricle, will pump blood into the aorta to pump it to the rest of the body. But what we can see here is there's these 2 arteries that come off right at the base here. And those are the coronary arteries. So we have the right and the left coronary artery. So these branch right off that base, and then they continue to branch into smaller and smaller branches, which will allow the entire heart tissue to have a method of retrieving blood supply for survival. But let's think about this for a minute. If you look at this left ventricle, and if it's pumping blood out under high pressure into the aorta and to the rest of the body, how do these little tiny vessels take any of it if it's under such high pressure? Wouldn't it just bypass it? Well, yes. And so our evolution has allowed for this neat little method of really kind of stealing some of that blood. So what we're going to do is we're going to zoom in on this area here and have a look. So just to orient you, this whole structure here is representing the aorta coming off of the heart. And these 2 little vessels here that you can see in both images are representing just short little snippets of the coronary arteries. What we have, if we look up close, are these valves that are present in the heart. And we talked about these already on an earlier slide, the aortic valve, also known as the left semilunar valve. And remember, I told you that when this left ventricle contracts and it pushes blood through that aortic valve and into the aorta. And so these valves have a unique shape. Can you appreciate looking at them, that they almost look like little containers or little cups? And so what will happen is when this left ventricle pumps blood through the aortic valve and into the aorta, these valves are going to be open to allow for the movement of blood. But once it's been pushed through and the left ventricle's done its job contracting to push blood into the aorta, the valve will close. And so this is showing you the closed valve. Okay, so a closed valve right here because the left ventricle's already pumped blood through. So the valves close, almost like a door that shuts behind the blood as it moves into the aorta. And because these are cup-shaped, what will happen is they'll collect just a little bit of the blood that didn't quite make it all the way through out of the aorta and into the rest of the body. And it'll collect that little bit and then it'll just trickle down into these coronary arteries in order to supply the heart with its own blood supply. So that's how the heart gets its own blood supply despite that high pressure system that exists, is it steals a little bit in these cup-shaped structures made up of the aortic valve, and that blood runs into the coronary arteries and into smaller vessels. All right, now we're going to really get into talking about the abnormal. Now, I don't need you to write this part down, but I want you to remember the normal anatomy of inside of a blood vessel and how it's made up of endothelial tissue. And endothelial tissue, a term I used already, is a fancy type of epithelial tissue. Remember epithelial cells that are found all throughout our body. These epithelial cells come together to form epithelial tissue. And when they're a part of blood vessels, that internal layer of blood vessels, and I'll just go back to show you that, the endothelium, the internal layer of blood vessels. When they're part of blood vessels, we call it endothelial tissue. And normally, this should be a nice, smooth surface for blood to flow through. So let's look at this as a blood vessel here and blood moving through containing red blood cells. And this endothelial layer that is lining the blood vessel that blood comes into contact with should be nice and a nice, smooth, healthy surface. Now, we also know from an earlier slide that blood vessels are made up of layers of smooth muscle that's part of that tunica media. And you might remember that smooth muscle is involuntary, meaning we don't have control over its contraction. And it makes sense because we're not controlling the movement of blood throughout our body. And this smooth muscle can relax or contract depending on whether or not we want more blood to move through or less blood to move through. So if I drew it like this, if this blood vessel here narrowed to this size, less blood's going to move through. If it widened to this side, more blood is going to move through. And so when we make a blood vessel smaller, I want you to make note that this is called vasoconstriction. The vessel is constricting, which will not allow as much blood to move through it. Or vasodilation if the blood vessel is widened, and that will allow more blood to move through it. In much of today's lecture, this online lecture, we're going to be looking at how an atherosclerotic plaque can form and how a thrombus can form inside of a blood vessel. If we look here, blood can flow nice through this vessel. But in people that have an atherosclerotic plaque, which is shown here that we'll talk about soon, you can appreciate that less blood can move through. It acts as a barrier or an obstruction. Now, what can happen in some cases is this atherosclerotic plaque can encourage the formation of a thrombus. And a thrombus is a blood clot. We will learn in this course that if this blood clot disengages or leaves from where it's located, it can travel as an embolus, and that can lead to an infarction but this will come up later. So I'm going to point out a few other things before we proceed. We know that less blood is moving through here because of the presence of this plaque. Now, with this plaque being here, I'm sure you can appreciate that this part of the wall where that tunica media is present is not going to be able to function as well because of this hardened surface. So we've reduced how well blood can move through because of the obstruction, but also because the walls can't contract as well to move blood in a forward direction. And so if less blood gets through, we'll learn that this is called ischemia, reduced blood flow toward whatever structures that blood was traveling to. And if there's a reduction in blood flow to an organ and it doesn't get as much oxygen, it can experience what's called hypoxia. These will be terms that will come up again and again, either me speaking verbally of it or it'll be demonstrated in text on the slide. And then in this case, you can see that complete blockage occurring, which means blood cannot move through at all. Or the clot that's formed here can dislodge, as already mentioned, and travel downstream, where it can lodge in smaller vessels, blocking blood flow downstream. So you heard me use the term atherosclerosis or atherosclerotic plaque. What is an atherosclerotic plaque? Well, let's break down some of the details. First of all, the term atherosclerosis. When it comes to words used in any medical discussions, you can oftentimes break down the word to know what it means based on its Latin or Greek origin. So if we look at the term atherosclerosis and break it down, athero means paste, and sclerosis refers to abnormal hardening. So this term then represents an abnormal hardening, also some thickening will be present of a blood vessel wall. And the reason for it is because we get this pasty buildup, which is referred to as a plaque. And based on the slide we already looked at previously, when a plaque builds up, it's going to cause narrowing of the artery. We can say more specifically, it's narrowing of the internal lumen. The lumen is just the area in the vessel that blood runs through. So if you think of even your gastrointestinal tract and where food moves through, it's moving through the internal lumen of the intestinal tract. If you think of a hose that water's moving through, it's moving through the lumen of the hose. Now, one of the most common locations of an atherosclerotic plaque to form is within the coronary arteries, and it can lead to what's called coronary artery disease. It can also be seen in the peripheral arteries. So we're talking about arteries that are in the periphery, which can lead to what we'll see later as well, called peripheral artery disease. Atherosclerosis is a form of arteriosclerosis. You can see these words are quite similar, but this word here, arteriosclerosis, is really an umbrella term. Arterio refers to artery. Athero, we said, refers to paste. Arterial refers to artery, sclerosis refers to an abnormal hardening. So this term here is abnormal hardening of arteries. And so when that abnormal hardening of arteries is caused by the formation of a pasty plaque formation, then it's called atherosclerosis. Just to back up for a moment, but you don't need to write this down, there are certain conditions that can cause somebody's arteries to harden. And that's where that term arteriosclerosis comes from. But again, when the hardening of the arteries is caused by plaque buildup or that pasty buildup, we call it more specifically atherosclerosis. It's important for you to know that it is a chronic disease of arterial blood vessels, meaning it develops over time. Somebody doesn't go from not having atherosclerosis to all of a sudden having full-blown atherosclerosis. It is a process that takes time to develop. So this plaque that I spoke of, This is a hardened tissue, and it's comprised of three main components: lipids, cholesterol, so these are both fats, and calcium. Now, we're going to talk about the cholesterol component in more detail on this slide and the next slide. Cholesterol, which is in our body, is carried by this, we can say, vehicle that's called a lipoprotein within the blood. Why is it carried in a vehicle? Well, you know or should know that our blood is composed of a lot of water. And we know that water and fat don't mix well. So if cholesterol is going to be transported in the blood, it can't do it very well on its own. So it needs a vehicle to carry it. And the vehicle, again, is called a lipoprotein. Now, lipoproteins come in two main forms that we're going to be talking about: high-density lipoproteins and low-density lipoproteins. And on the next slide, I'm going to talk about the differences between these, but I just wanted to mention something first about cholesterol. Cholesterol, despite most people associating cholesterol with bad health, cholesterol is needed in our body. We use cholesterol to make things like steroid hormones. They have the basis of cholesterol. You don't need to write this part down. It is also used to make vitamin D. Cholesterol is also an integral part of our cell membranes, thinking back to the plasma membranes and how they had cholesterol located or embedded within the plasma membranes to help with the overall integrity of the cell wall. On the next slide, I'm going to be talking about the two different methods of transportation via lipoproteins, and which ones are good and which ones are bad. So on this chart, I have high-density lipoproteins and low-density lipoproteins and some of the important details listed beneath. The first important thing to note is that high-density lipoproteins are referred to as the good vehicle for cholesterol, whereas low-density is the bad. And how to remember the difference? Well, high-density lipoproteins should be high in our blood. Low-density lipoproteins, we want to keep them low. The high density, the ones that we want high, the good cholesterol, you can think of that H as also representing healthy. This is our healthy vehicle of cholesterol movement. Whereas you can think of low density as the L for lethal. High low density lipoprotein, high LDL, can cause major damage, as we'll see. So what's the difference? What do these different vehicles do? If we know that these lipoproteins carry cholesterol, well, where do they take them? Let's start with LDL and what it does. When you eat food, the nutrients that you absorb, you might recall, will be absorbed into venous vessels and travel to your liver. That's the kind of the pit stop that the nutrients we absorb make. And cholesterol is the same. So any cholesterol that you consume and any cholesterol that you make at the level of the liver are going to end up traveling to your body tissues, just like other nutrients, so that your body tissues or cells can use the nutrients, and in this case, use the cholesterol for whatever purpose it needs to, whether it's to make vitamin D or to synthesize certain hormones such as steroid hormones, or to just rebuild some of their plasma membrane or the structure within the plasma membrane. But eventually the cells in our body are going to say, okay, that's enough cholesterol. We don't need any more. And that cholesterol is going to stay in the blood. And the cholesterol is going to stay in the blood and get bored and end up causing damage, as we'll see soon, to the endothelium. So what we can say about LDLs then is we know that they're going to take cholesterol into your blood, to your tissues. And that excess is going to hang around. And so LDLs really increase the amount of cholesterol that's going to be present hanging around in our blood. And the more hanging around it does in our blood, the greater chance there is of plaque formation, as you'll see soon. Now, fortunately, we have this other vehicle called high-density lipoprotein. And what this vehicle is going to do is it's going to take cholesterol that was hanging around in the blood, and it's going to bring it back to the liver. And then the liver is going to decide what to do with it from there. It's either going to allow it to be excreted so our body gets rid of it, or it's going to use it for some sort of domestic purposes. So what this does, because it's the vehicle that almost like picks up the trash, takes the excess cholesterol in our blood to the liver, getting it out of our blood, this reduces the amount of cholesterol in the blood. And the less cholesterol we have in our blood, the less chance of plaque formation. I'll show you a picture on the next slide, but if we look at a lipoprotein and we break up the word, lipo means fat and protein means protein. So this vehicle then is made up of lipids, fats, and proteins. But the proportion of each is going to be different in an HDL vehicle than an LDL vehicle. And so it might make sense to you that with HDL, that good cholesterol, it's going to be made up of more proteins. Whereas the bad cholesterol is going to be made up of less proteins and more lipids, but we'll see a picture of that soon. We'll also see that HDLs are smaller in size. The LDLs that have more lipids and less protein are larger in size. We know already that if HDL is going to take cholesterol out of our blood, then this is going to reduce the chance of plaque formation, which in turn reduces the chance of coronary artery problems, stroke, and death. Whereas LDL is going to be just the opposite. This cholesterol is going to hang out in the blood, promote atherosclerosis, the formation of these plaques, which can then lead to heart and brain events as well as death. So overall, when we look at HDL, the healthier cholesterol, it's going to improve endothelial function by taking out cholesterol out of the blood. It's going to reduce the oxidation of LDL, and this will make much more sense soon. We'll learn soon that if LDL hangs out in our blood too long and damages our vessels, it can become oxidized. And oxidized LDL is very damaging, but I'll come back to that. HDL has anti-inflammatory, so it will reduce inflammation, so anti-inflammatory properties, and it will also inhibit or prevent the aggregation of platelets or clotting cells. That will also make more sense soon. But LDL, the problem vehicle, is going to increase the risk of the cholesterol becoming oxidized. And oxidized cholesterol is going to cause damage to the endothelium, it's going to promote inflammation, and it's going to cause platelets to just aggregate or congregate together in an area. And what happens when platelets kind of clump in an area? Well, it forms a clot, and that can block the normal flow of blood through that vessel, as we've already talked about. So continuing on with that, I wanted to show you here the difference in appearance and composition of HDL versus LDL. If we look at the proportion of lipids to proteins shown in green, as mentioned on the last slide, higher proteins, less fat or cholesterol. But if we look at the LDL, you can see there's a lot more fat or cholesterol, and represented if you look at the color, and then less proteins. You can also see the difference in its size. So when you ingest fat, your body, your digestive tract, I should say, is going to take that fat, just like it does other macromolecules that you ingest, and break it down into a form that we can absorb. And that form that we can absorb are called fatty acids. So backing up, I eat some fat, it gets into my digestive tract. I have enzymes that break down that fat into smaller forms, including fatty acids. I absorb the fatty acids it's a venous system that will travel first at that pit stop area to the liver. And what the liver is going to do with those fatty acids, it's going to convert them into triglycerides, which are a fat, representing 3 glycerols. And what will happen here is those triglycerides that came from the fatty acids are going to come together with phospholipids and cholesterol. All of these three are fats to form a low-density lipoprotein. So in other words, the vehicle that carries the cholesterol that I spoke about earlier, carrying it to your tissues, is comprised of triglycerides, phospholipids, and cholesterol. There's also another form of LDL called very low-density lipoproteins, but we're not going to be talking about that in this course. Once the liver has really formed these LDLs, they're going to be released into the systemic circulation, right, as we've already talked about. We also know, that I talked about on the last slide, that HDL is going to be that major vehicle for taking that cholesterol that is just kind of hanging around in the blood and picking it up to form the high-density lipoproteins, picking it up from our peripheral tissues and the blood that's in that area. And we know it's going to take it back to the liver, where the liver will allow our body to get rid of it, or it'll use it for some other useful purpose. In brackets, you can see that HDL is also going to be transporting cholesterol from macrophages and endothelial cells. And I'm going to tell you what this means now, but it will make more sense once I talk about the formation of an atherosclerotic plaque soon. So maybe just listen for a moment so that you're not getting too confused about what you're writing down. What we'll see soon is that when we have damage to endothelial cells from cholesterol, macrophages, which are a part of our immune system, are going to try to help and clean up that area by kind of engulfing any of the LDL that's there that's been damaging the endothelial or the inner layer of our blood vessels. And so HDL can actually help clear out some of the macrophages that have been kind of eating up the LDL. Because what we'll see soon is that these macrophages that eat up the LDL, they can actually inadvertently contribute to the formation of an atherosclerotic plaque. And so HDL can help get rid of these kind of cholesterol-filled macrophages so that they don't promote further damage to endothelial cells. But if that's confusing now, don't worry, I'll be getting into more detail on that soon to clear that up. Risk factors for atherosclerosis, so just taking a bit of a break from the more intense discussions on pathophys. We have what are called non-modifiable and modifiable risk factors that can contribute to the development of hardening of the arteries from the formation of a plaquey, pasty substance. Things that are non-modifiable are things that you can't control. You can't control your age, whether you're male or female, genetic factors, your race, your ethnicity. And there are certain details with these risk factors that predispose somebody to developing atherosclerosis. With aging, it's thought that one of the reasons is that over time, there's just more and more free radical damage that can damage how our blood vessels respond to the presence of LDL. In terms of male versus female, there is a greater risk in men at a younger age and a greater risk in women at an older age. And 55 tends to be that number where it's more common in men under the age of 55 and more common in women over the age of 55. Genetics, well, there could just be family history of certain things such as high blood pressure, for example. Modifiable risk factors are things that, for the most part, you can control. It might be harder for one person over another, but these are things that we can modify in order to reduce the risk of developing atherosclerosis. But also things that we can modify if we already have atherosclerosis to reduce the effects that atherosclerosis can have otherwise. Hypertension is high blood pressure, smoking, diabetes, not exercising, being obese, having just overall high cholesterol, which is greatly contributed by a poor diet. So changing these variables can not only change the risk for developing atherosclerosis, but can also affect the potential side effects or outcomes that can occur if somebody has atherosclerosis. So development of atherosclerosis. This is absolutely an important slide for you to be aware of. Remember, atherosclerosis is a form of that umbrella term arteriosclerosis that I mentioned earlier, but this is caused specifically by plaque buildup. So how does this happen? How do we go from a healthy inner lining, that endothelial lining that's nice and smooth, to something that becomes damaged? Well, these endothelial cells, you can actually see the cells that make up the tissue if you look closely here. These endothelial cells that make up that inner lining of our blood vessels can become damaged or injured. Why do they become damaged? Well, this goes back to the risk factors such as smoking and age and poor diet and lack of exercise can all contribute to injury to these cells. Basically because the body is going to not respond properly to some of the chemicals that are running through the blood vessels. Maybe the pressure is so high within it that it damages the blood vessels. And anytime there is injury, there's going to be inflammation. Okay, we can associate those two together in most cases. So now we have this person that has damage to the endothelial cells and an inflammatory response occurring. But what this person also has is high levels of LDL in their blood, higher than normal, and probably lower levels of HDL. And so this vehicle that is carrying cholesterol that's sort of hanging out in the blood and getting bored because the cells don't need it and there's not enough HDL to transport the cholesterol back to the liver, the LDL and the cholesterol within it gets bored hanging around in the blood. And so it all of a sudden sees that there is damage to the endothelium. And it sees that and it thinks, oh, well, that's something new. And so what the LDL, the cholesterol, is going to do is it's going to say, let's see what's behind this door. And it moves in through that injury underneath that endothelial lining. And you can see that if you look close here, these lipids, this cholesterol here. Okay, it was hanging out in the blood, then it sees this injury here and it thinks, I'm going to check that out and see what that's all about. So it's entering through that tunica intima. Now the LDL, the lipids that are in the cholesterol that's now underneath this tunica intima, becomes oxidized. It becomes oxidized because there's free radicals that are present here, and what'll happen is you'll get this formation of these injurious chemical bonds and causing what's called oxidation. And so oxidized LDL is now going to be pro-inflammatory. Anytime you hear oxidation, generally you can think of pro-inflammatory. It's causing inflammation. So now we have even more inflammation occurring. And so when there's an inflammatory response, the body's natural response to that is going to be, okay, well, let's get some white blood cells there to help clean up whatever problem is occurring. And so our body will end up sending phagocytes to the area. Phagocytes are different types of white blood cells that have the ability to phagocytose, which means eat and consume something that maybe shouldn't be there. And so if I zoom in on this image to show you what I mean, we have those LDL that have penetrated through that damaged endothelium, that damaged tunica intima. And phagocytes, such as monocytes, are going to arrive at the area And they're going to want to go in here too and clean these guys up because they're thinking, well, those shouldn't be there. There's this inflammatory response occurring. I'm going to go in there and I'm going to eat all of those guys up or phagocytose them so that they're no longer a problem. So our body's trying to do something about this, but as you'll see, it's not very effective. You might remember from normal anatomy that monocytes, again, monocytes are a type of phagocyte. Monocytes are a white blood cell that when they get to the area that they're going to do work, they have this ability to really transport themselves, or I should say, or change into a bigger cell, one called a macrophage. So a monocyte can differentiate into a macrophage, which is a larger cell. I usually describe these as being kind of like a Pac-Man, if you know what that is, where they're larger and they have an easier ability to phagocytose or eat things that should not be present. So let's zoom in again. So this monocyte here, which we saw originally up here, is going to go into this opening. It's going to differentiate into a macrophage, as already mentioned, so a larger form of itself to do the job better. And it's going to start engulfing, as you can see. So this macrophage here is now engulfing all of these lipids, or what we talked about, the LDL. And it's engulfing them to get rid of them. It's like, let's get rid of these, they shouldn't be there. But this sort of weird reaction occurs where when these macrophages engulf these fats, it eats so much oxidized fat that they transform into something very different called a foam cell. So a foam cell then is really just a macrophage that had way too much oxidized LDL for dinner, and it became this much larger cell that can't really do anything productive. And it's eaten so much, it just kind of hangs out there as this big fat cell. So these foam cells, and we're going to have a lot of them because look at in this simplified example, only showing you 3, but there's going to be a fair amount of macrophages here that are all going to be engulfing, and then they almost kind of form together and form this fatty streak filled with fat. So the foam cells then form that fatty streak, which is really what you see here and here. You can even see it kind of here as well. So this is where our body's trying to do something good, but it's just not very successful at doing it. Foam cells, okay, what we just spoke about, are going to promote further injury in the state that they're in. They're going to release these cytokines. Cytokines are like cell signaling, so they kind of get stuck where they are and they just start sending out all of these chemicals in an uncontrolled way. And this promotes further injury. Foam cells also have this ability to release growth factors. It's almost like this fatty streak that forms from these macrophages that ate way too much oxidized LDL. It's almost like they just start spitting out all these chemicals to try to get help, to try to get out of the circumstance that it's in. But it fails and it actually makes things worse. But the growth factors that it spits out, what they're going to do is stimulate the production of smooth muscle. And smooth muscle, and remember smooth muscle here is all part of our tunica media. When we produce more smooth muscle cells, and you can see more being produced here, these additional ones, they're going to produce collagen. Collagen is really something that is a hardening agent when it's present. So we have collagen in our skin that contributes to the integrity of our skin, for example, and then with age we lose some of that collagen, so you lose some of that integrity, that hardness that we would get with our skin, and then wrinkles can form and so on and so forth. So this collagen, though, it's not a good thing. The collagen kind of gets all produced through here and it lands itself all throughout here, kind of surrounding that fatty streak. almost creating a cap of all of these smooth muscle cells that have produced collagen that all forms along here and caps off that fatty streak, making it hard. And if this whole area here is hardened because of the collagen formation, it's not going to function as well. All the normal abilities of this area of the vessel are now affected. And so this takes time, and that's why I told you that the formation of an atherosclerotic plaque is a chronic condition. It takes time to develop. The last thing I wanted to point out is that if we look close at the formation of this hardened area with this fibrous cap, this is really the atherosclerosis that has been formed. We have the hardening and we have the streak that has formed here, that pasty plaque. What we have here is these little fissures that have formed. And these are like little cuts now within the blood vessel wall, all a part of the damage that has occurred. And what this will do anytime we have a cut or bleeding is attract platelets, which are clotting cells. And what these platelets will do is they'll rush to the area and start clotting throughout here because it's trying to deal with an injury as it normally knows how to do. And the bigger the clot that forms through here, the more likely it is to block the normal flow of blood throughout the vessel, acting like an obstruction. And as I mentioned to you earlier, if any part of a clot that forms, and it's not explicitly shown in this image, part of a clot can break off and travel downstream and end up really blocking blood flow through smaller blood vessels, leading to the terms I referred to earlier, ischemia and hypoxia. Here's another image describing much of the same thing. To orient yourself, this here would be the lumen of the blood vessel. These are the endothelial cells that make up the inner lining of our blood vessels. And then we have, so that we talked about the tunica intima. And then moving more external, you can see the smooth muscles quite nicely. So what we discussed happening is some injury, let's say the injury is here, some injury or break here in the blood vessel wall can cause LDL, if in higher amounts than it should be, to enter through there and end up penetrating through that tunica intima. And then they kind of hang around here, but there's free radicals here. And these free radicals are kind of excited and they're looking for something to bind with. And it forms this injurious chemical bond. So a chemical bond that can cause injury. And what we call that is oxidized LDL. So this is LDL, and then oxidized LDL just is represented by the sort of crown on top. Then what's going to happen is this inflammatory response that occurs that attracts monocytes to the area. Monocytes are thinking, oh, we got to go help clean up this area. And then when they get there, they think, this is a job for a bigger version of myself. And they transport or transform themselves, I should say, into a macrophage. Okay, so they enter in, transform into a macrophage, and they're going to start consuming this oxidized LDL shown here. And they consume so much of it, you can even see some of the smooth muscle here is being damaged in the process, that they form this like big, huge like cell and multiple cells that have converged together full of these oxidized lipids. Remember I had mentioned to you that the foam cell will all of a sudden, not sure what to do, start releasing all these chemicals, including cytokines, which promote further damage. And you can see some of that damage here. And also they will produce growth factors. And I'd said that those growth factors will produce smooth muscle, and the smooth muscle will produce collagen. And that's where we get that. You can see the blue here is representing the collagen, which is going to migrate around here and create this fibrous cap. So this atherosclerosis, remembering that it's a chronic condition and takes time to develop, can lead to many different complications, including coronary artery disease. So that's disease affecting the coronary arteries. So think about it. If you have your heart that has these coronary arteries and then the smaller branches off the coronary arteries that supply the heart, and all of a sudden they're now narrowed because of plaque formation, it means the heart's going to get less oxygen. And you can, I'm sure, appreciate why that would be a problem. Peripheral artery disease, so we're talking about any arteries in the periphery. Arterial hypertension, we'll talk about that later, as high blood pressure within the arteries. Ischemia, we know, is a reduction in blood flow through an artery. And less blood flow through an artery means that the cells distant to it that would normally be getting nice flow of blood are now getting less, and they can experience hypoxia, which is low oxygen. Aneurysms can form where we get ballooning of arteries, so the walls become weaker and start to balloon out and can rupture. Angina, we'll talk about this, which is a chest pain that can occur because of atherosclerosis. An infarction is where blood is not moving through an artery enough to supply the basic metabolic needs of a tissue, and the tissue can start to die. I'm sure you've heard of a myocardial infarction before, so that's where a heart attack. But there's also other infarctions that can occur within the brain and within muscle tissue, among other areas. Thrombus formation, I talked about that as well. That's where a plaque that forms here can have some little ruptures within it, or cuts almost, that attract clots to the area, or rather platelets to the area, which form clots. A clot is referred to as a thrombus. I already spoke about how that can be damaging. We will be elaborating on many of these terms in subsequent topics under the cardiovascular disorders lectures. Now, how bad is atherosclerosis? Well, we know it's a chronic condition, but it can lead to acute complications, meaning that something that can occur suddenly. And one example is that if an aneurysm forms, they can burst. And this is showing you a ruptured aneurysm, and that can be life-threatening because a lot of blood loss can occur. We'll talk more about aneurysms later. Some other complications that are acute can be due to the sudden formation of a thrombus that can completely block a vessel or travel downstream and block a blood vessel. So I talked about this already with these fissures that form, how they can attract platelets to the area. Now this is showing you what the clot looks like when it forms, and you can see that it's occluding the blood vessel even more than it did when it was just a plaque formation. And remember also that part of it can dislodge and travel downstream. And so this blockage, if it occurs in the heart, can mean that some of the heart muscle's not getting enough blood flow suddenly, and this can lead to chest pain. We'll talk about angina later. If it's blocked fully, it can cause a myocardial infarction or a heart attack, an MI, where death of tissue can occur. I also spoke about how if part of this thrombus breaks off, it acts as what's called an embolus. You can think of an embolus as being a part of a clot that has broken off and is now traveling. An embolus is really a traveling clot that can travel downstream, and it's going along downstream, and all of a sudden vessels get smaller and smaller, and then eventually the clot, that traveling clot, will block the blood vessel entirely, which means that somebody could have blood flow blocked to the brain, causing a stroke, blood flow blocked in the heart, causing a heart attack, even blood flow to a muscle or other areas of the body. So if we look at these images here, this is showing you a narrowed blood vessel due to likely atherosclerosis. And blood can still get through, but in this second image, it's progressed and blood is completely blocked off from, that's complete occlusion. And you can see there's no evidence of blood flow here. And then they're given medications in order to open up that vessel so that the heart muscle can receive blood supply before it would otherwise start to die. Okay, arterial disease, which is really speaking generally about disease of arteries within the body, is going to be any disorder that is going to narrow or occlude the arteries, really causing ischemia. And the most common cause of arterial disease, won't surprise you, and what we've already talked about, is atherosclerosis. There are two main arterial diseases, those that affect the heart, so coronary artery disease, and those that affect arteries in the periphery, called peripheral artery disease. You need to be aware that the most commonly affected arteries are going to be those coronary arteries, the blood vessels that supply the heart muscle, which is known as the myocardium. But when it comes to peripheral artery disease, it's going to be affecting blood vessels that supply primarily your lower limbs. In other words, although somebody can get peripheral artery disease anywhere within the periphery, the most commonly affected area are the blood vessels, the arteries that supply the lower limbs. And of course, keep in mind that the brain can also be affected by atherosclerosis. A little bit of background on the coronary arteries. In addition to what I've already spoken about, the heart muscle I told you is called the myocardium, and the myocardium, if you look at all the layers of the heart in this cross section, it is the thickest layer, and we need the myocardium to be thick to pump blood throughout the heart, but also to the lungs and to the rest of the body. But the thickness of the walls of each chamber, remembering the two top chambers, left and right atrium, as well as the left and right ventricle beneath it, the thickness of the walls of each of those chambers is going to be proportional to the distance that the blood has to travel. In other words, we know that with the right atria, all it has to do is pump blood to the right ventricle. But the right ventricle has to pump blood a little bit further to the lungs, so the muscle is going to be thicker. The left ventricle, on the other hand, has to pump blood with enough pressure to the rest of the body. So it is going to have the thickest muscle, which means it's also going to have the most supply, arterial supply, in order to meet the metabolic needs of that muscle. Now, in talking for a moment about coronary artery disease specifically, if any of the coronary arteries are narrowed or completely blocked, or maybe there's a thrombus that is causing the blockage, it is going to mean that the muscle of the heart distal to that is not going to be getting the proper blood supply that it needs to contract properly. And obviously the heart contracting properly is necessary to push blood through the pulmonary and systemic circulation. But blockage specifically of the left coronary artery, the circumflex artery, and or the anterior interventricular artery, so these are really extensions of the left coronary artery, will mean that the left ventricle will be deprived of oxygen, which means that that left ventricle might not be able to function properly, which means that the rest of the body will become deficient in receiving the oxygen that the rest of the body needs for survival. So let's break that down. Let's say there's an atherosclerotic plaque found somewhere within the left coronary artery or one of the extensions, or even one of the other arteries that do supply the heart. It means that there's less blood flow being delivered to the myocardium of the heart. In our example, we're talking about the left ventricle, remembering that the myocardium is the muscle of the heart. Less blood flow, which we would call ischemia, means that there's less oxygen or nutrients that the myocardiocytes, which are the cells, the muscle cells that make up the myocardium, they're not receiving the oxygen and the nutrients to the extent that they need to for survival. for normal metabolic processes, and then they fail to function properly. And what happens if the myocardiocytes that make up the myocardium fail to function properly? Well, that left ventricle is not going to be able to pump blood effectively into the systemic circulation. Now, if somebody has some narrowing of these arteries because of an atherosclerotic plaque, they may not notice any signs or symptoms until maybe they start to exert themselves and exercise. And when they do, all of a sudden, this heart muscle is working harder during exertion. And if it's working harder, it needs even more blood flow containing oxygen and nutrients. But if it's not getting that increase in blood flow that it needs during exertion because that atherosclerotic plaque has narrowed the lumen of the artery, then it can cause chest pain. And this type of chest pain is called stable or predictable angina. And what this means is that a person exerting themselves can get chest pain, what we call angina, and it's predictable because they know if I start to work out, my chest is going to start to hurt. And it's really referred to as stable because if they stop exerting themselves, then the pain goes away. I will also later in this topic discuss the difference between stable and unstable angina. So the overall effect that we're seeing then with this atherosclerotic plaque in the coronary arteries is that less oxygen and or nutrients are going to be reaching the systemic tissues. The systemic tissues themselves being all the tissues of your body that left heart would be pumping blood out towards. So less blood reaching these tissues, reduction in blood flow, is ischemia, and there's also going to be hypoxia because the cells themselves don't have enough oxygen to allow for normal metabolic processes. Now, if this left ventricle fails to pump the normal amount of blood out into the aorta and then into the systemic circulation because it just can't contract hard enough because of a reduction in blood flow to the heart muscle because of atherosclerotic plaque within the coronary arteries, then some of that blood is going to remain within the left ventricle because we can't pump it all out. And the more blood that remains here, well, it's still going to be filling with blood. And if we don't pump out enough, then it continues to fill too much, which actually puts a lot of pressure on that left ventricle. And as we'll learn later in this course when we talk about heart failure, if this left chamber here in the ventricle continues to fill with blood, and it expands, it's eventually going to put pressure on that left atria above it, which can, in fact, cause the blood to back up from the left ventricle to the left atria and then back into the pulmonary circulation. And this can lead to life-threatening problems as that left heart fails. We will get into a lot more detail, an entire lecture just on heart failure, so what I spoke there was just an introduction. If somebody is experiencing atherosclerosis within a coronary artery, for example, that is causing narrowing of the lumen of that artery, meaning less blood can move through it, as I just discussed on the last slide, there is a procedure that can be done called a balloon angioplasty to open up that lumen wider despite the presence of that atherosclerotic plaque. So the term angioplasty, angio refers to blood vessels, means using a balloon to stretch open a narrowed or blocked artery. And so how this will be done is a catheter will be inserted into the vessel. It will travel through the vessel until they reach the area of concern. And a balloon will be inflated to open up that vessel, so increasing the lumen size or the diameter of the vessel to allow more blood to move through it to reach the heart muscle. In some cases, stents have to be placed. So a metal coil or tube, and you can see the metal coil that is shown here and the balloon that's shown here. And what this will do is remain where it is to keep that vessel open. Balloon angioplasty can really be done anywhere that it's needed, and there are different access points for which a catheter will be inserted to gain access to the artery that's affected, but the coronary arteries are a common location for this procedure. So that was coronary artery disease. Now we'll look for a moment at peripheral artery disease for our last two slides. Peripheral artery disease involves atherosclerotic plaques within the peripheral arteries, and when this occurs, it means that less blood can move through the peripheral arteries to reach more distal areas of the body, including the lower limbs, as mentioned earlier in this lecture. And this means that because of reduction in blood flow, ischemia, that the cells distal to that atherosclerotic plaque or that narrowed artery are going to experience hypoxia. Now, anytime there is ischemia or hypoxia, it is very important to correct the problem as soon as possible and restore normal blood flow, because if you don't, tissues in the body can experience necrosis or death of tissues. This can lead to, if necrosis occurs, ulcerations that start to show up on the person's lower legs. Now, this is especially prevalent, and this is important for you to know, in two populations, diabetics and those who smoke. One of many reasons why it is very important for those with diabetes to check their lower limbs, because people with diabetes already have, in many cases, a reduction in the sensation of pain, for example. And so they may not notice that they have ulcerations. On our final slide, having a look at the stages of peripheral artery disease. What we see with stage 1 of peripheral artery disease is that these affected individuals who have this reduction in blood flow to the lower limbs have an absent or weak pulse in the arteries that supply the legs and the feet. So it's difficult to feel the pulse because the arteries are not receiving the same blood supply through them, and the blood itself is not exerting enough of a pressure against the walls because of a reduction in blood volume to create a pulse. Stage 2 involves intermittent claudication. Intermittent means it comes and goes, and claudication is really a cramping. And so that's described down here, where pain and cramping can be experienced in different areas depending on what's affected in that person, such as the hip, the thigh, the calf muscles. And this tends to occur when they're exerting themselves. So walking, climbing stairs, and that's because when they're exerting themselves, all of a sudden these muscles need more blood supply, but they're not getting that increase in blood supply because of the narrowed arteries. And then the term intermittent, meaning the pain comes and goes. So they'll rest and say, oh, the pain goes away. With stage 3, so with progression here, now these individuals are getting claudication or that cramping even without any physical exertion. They might have temperature changes within their leg or foot, so a coldness sensation because of a reduced blood supply. In stage 4, this is where development of ulcers occur, and these can be very challenging to heal. The skin can start to show color changes, slower growth of hair and toenails, and just overall poor healing. So this is not a stage that you want to find a person in. You want to catch it early on to allow for repairs to occur. That's the end of this lecture. Thank you so much for your time. Bye for now.